to which we've all been linked linked on these online platforms. So I'm sitting in a small rural part of Australia, recording this webinar, and we're all scattered, throughout the world, but we're connected by a common interest and by a common profession. And the one thing that I have learned as I travel around the world is I've learned how similar we're vets, regardless of where we practice. Last year, I had the privilege of visiting China for the first time, a very sort of different cultural experience for me. But what really struck me was how similar we vets are wherever we are. We're a very similar animal. So it's very difficult to cover such a vast topic like flexible endoscopy or endoscopy in general in an hour or so. So I'm going to do my best to try and at least familiarize yourself with the clinical value of endoscopy as a tool in practice. If you have zero experience in flexible endoscopy or endoscopy in general, this will be a good starting point for you. If you already have some proficiency and you're using this equipment, this will be a good base for you to build on top of. Ultimately, what I would highly recommend is that once you have gained some proficiency in endoscopy, it's really great if you can have some sort of wet lab experience or workshop experience, or if you're able to visit a center that is doing endoscopy, just to hone your skills. It's like anything in practice. The more you do it and the more you expose yourself to it, the better you get at it. So I'm going to start off by, I guess, really starting with the bare basics of endoscopy, flexible endoscopy. And what I wanted to start with is, I don't know what it's like where you might be in the world, but here in Australia, and certainly when I was in South Africa and in New Zealand for that matter, there are very few GP practices that have endoscopy. And so the question is, why is endoscopy, which is becoming more and more readily available, the equipment is becoming more affordable, the access to training is becoming easier, and yet the uptake is still quite low. There are a number of reasons for it. Expense is a major reason in my experience. In the past, the equipment has been quite expensive. There's a bit of a cost barrier to that. And fortunately, this cost barrier is lowering, particularly as companies, more and more companies are investing in the veterinary space. Another major factor, though, is expertise or training. So many veterinarians, I've taught into undergraduate programs now for close to the last 10 years in 3 different countries. There's no endoscopy training really at an undergraduate level, certainly in none of the universities that I've worked in. And so the only experience that a veterinary undergraduate might have or exposure to endoscopy is if you happen to have a case when you are on a clinical rotation, and then you would have just been an observer. So there was no formal training at all in undergraduate programs, certainly the ones I've been involved in endoscopy. And so expertise becomes and exposure at an educational level is another barrier to endoscopy. And then there's also the perception of exclusivity or of the fact that endoscopy is something that is limited predominantly within the specialist field. And so these are some of the reasons why the uptake to endoscopy in general practice has been quite low. So, of course, the corollary to that is, well, why should you get an endoscopic unit? Why would you invest in this equipment? If you are doing it already, why should you carry on doing it? Well, these are the things that I've discovered over the years in clinical practice, but particularly with minimally invasive diagnostic modalities like endoscopy. There's an aspect of welfare, of compassion, of lower impact diagnostic procedures. And so endoscopy significantly reduces the morbidity of diagnostic procedures. All of my patients go home on the same day. So if they come in for GI endoscopy, rhinoscopy, bronchoscopy, any oscopy, anytime I put a scope into an animal, it's a rare exception that they wouldn't go home on the same day. Now, many of us will send home exploratory laparotomies on the same day, but the morbidity associated with that and the risk associated with it is significantly higher. And so we are significantly reducing the amount of discomfort or morbidity that we inflict as practitioners with endoscopy. Then there's also the aspect of these procedures being safer. So in particular, if you are collecting intestinal biopsies and you're going to biopsy the duodenum and the jejunum and the ileum, you're probably not going to do a full thickness biopsy of the colon. You might, but there's a risk associated with that. Whereas with flexible endoscopy or endoscopy, I'm able to collect biopsies and actually start treating immediately, and the risk of perforation or dehiscence is quite low. And then there's cost. So it's probably not the same in general practice, but in referral practice, for me to do an endoscopic procedure compared to a specialist surgeon spending an hour in theatre, there's less cost involved. Although the equipment that we're using can be quite expensive, the actual cost of the procedure tends to be lower when it's an endoscopic procedure. And then we also, another reason to get it would be to expand your repertoire of services and to enhance your reputation as a clinic or as a care provider by virtue of offering a sort of a comprehensive range of diagnostic tools. And then many of us may just be employees in the industry. We don't really have as much of a concern from a business perspective. But the reality is, in most parts of the world, is veterinary practices are businesses. And in order to grow the business and invest in it and to have decent equipment and to have nice work circumstances and to be able to pay our staff appropriately, we do need to differentiate ourselves from others. And so we do, to some extent, need to compete, not necessarily with our colleagues, but to compete with the standard and improving the standard and taking our clinical skills forward. So then there's this concept, and it's probably something that might not even be relevant in your country, depending on where you are, but here in Australia, to some extent, other parts of the world, there's this concept of the scope of practice, no pun intended. So is endoscopy typically a specialist procedure? Well, in my opinion, it's not. I think there is very much a place for endoscopy in general practice. If I use the Australian example, which I suspect is very similar to many of the countries that you might come from, there's still very few specialists. I noticed someone was saying hello from Portugal. I have a very good friend who's an internal medicine specialist who's Portuguese. She's in the UK, and to my knowledge, that's how I know there are very few specialists and correct me if I'm wrong at the end, but to my understanding, there are not many specialists in that country and in many European countries, parts of Asia. So, and certainly in Australia, New Zealand, South Africa, there's still not that many specialist hospitals in comparison to the number of general practice hospitals. And so it's important that the services, these services that are important services that reduce morbidity, that are important from a welfare aspect, are offered by our profession. And then the other thing to think about is many GP vets will learn to do TPLOs. So I'm not a surgeon, but cruciate surgery, will learn to do advanced orthopedic procedures, but often are quite resistant, not resistant, I beg your pardon, reluctant to look at advanced diagnostic procedures like endoscopy. And so I'd encourage you by saying that basic endoscopy is not difficult. It's like any clinical skill that you're going to learn, whether it's interpreting radiographs, whether it's doing an abdominal ultrasound. The more you do it, and the more you you become familiar with the anatomy, and the more you become familiar with the diseases that we can diagnose, the better you get at it. And then also, I've practiced in 3 countries where there is a culture of feeding dogs bones. And I would say, of all the countries I've worked in, New Zealand is probably the one where there was the strongest culture of feeding bones. And so dogs that are fed bones are going to get esophageal foreign bodies. And this will often be in rural areas. And so it might not be feasible in Australia, Queensland alone. I can drive over 3,000 kilometers and still stay in the state. And so it might be that a client, particularly in a regional area or rural area, just can't get to a specialist center. And so things like esophageal foreign bodies, endoscopy has no equal as far as that procedure goes. So I guess I'm trying to make the argument that if you are reluctant to perform endoscopy, or you feel like this is something that's limited to specialist practice, is to encourage you to not think that way and rather focus on actually improving and honing your clinical skills. So we spoke a little bit about the cost barrier. Now, there's often a cost barrier for veterinarians, and I'm sure vets are the same wherever you go in the world. Particularly practice owners, is they always want to see a business case for the equipment. And to put it into context in Australia, and you can do the mental conversion, the currency conversion, but it can cost $100,000 to set up an endoscopy unit. And so you can spend a lot of money on endoscopy. And this is where the TK Vet system is something that I think is really making an inroad in the veterinary endoscopy space, because that cost barrier is significantly coming down, and these units are small and compact. They don't take up a huge footprint. So when I started endoscopy, it was quite common to have reconditioned towers from human hospitals, and these are very, very bulky units. They take up a lot of space in your practice. They're very heavy. And so these TK Vet systems are quite nice and compact. You can kind of hide them away in a corner of your practice. And they're not in terms of the other equipment that's out there, it's not hugely expensive. Just to put it into perspective, we usually are charging between 1,000 to 3,000 Australian dollar per procedure. I know that with the recent trade wars, the Australian dollar has suffered against the US dollar, but that just gives you a rough idea. So if you're looking at setting up a business case for endoscopy, if you're looking at it in my world, to pay for the equipment within a few years, you typically only need to be doing about 1 procedure a month. So obviously you want to do more than that, but in actual fact, paying for the equipment, if you charge appropriately for it, and you're in a practice that has a relatively high caseload, paying for it shouldn't be a huge issue. So where would you start if you didn't have a unit? So for those of you who haven't yet invested, or maybe those of you who have old horrible equipment like I used to have when I started in GP Vet, and then you want to upgrade, well, you normally want to start with some sort of needs analysis in terms of, are you going to be using this equipment? And if you are doing, if you're seeing a lot of GI stuff like I do, we have a lot of poodles and moodles, and these are very popular dog breeds here, Groodles, and these dogs are prone to chronic GI problems. So if I had shares in hydrolyzed diets, I'd make good money, because we're putting things onto hydrolyzed diets and doing a lot of endoscopy to diagnose inflammatory bowel disease. So if you have cases like that, you're going to keep your unit busy. Most of the flexible endoscopy I do is GI. I do some flexible endoscopy for males, cystoscopy, bronchoscopy, and even rhinoscopy. I'll use small flexible scopes in some dogs for rhinoscopy, but the vast majority of what I'm doing with flexible endoscopy is GI endoscopy, upper and lower. And then esophageal foreign bodies. I'm not. I don't currently have. I'm not currently doing a lot of after hours work, but whenever I've done any after hours work as an internist, 90% of what I do is take out esophageal foreign bodies. So esophageal foreign bodies is a common use for an endoscope, particularly in the emergency settings. And then if you're looking at what you need, you typically for a flexible scope want something with an outer diameter somewhere in the region between 6 to 8 millimeters, around 6 to 7 for cats, 7 to 9 for dogs. You need a pump and some insufflation so that you can inflate the intestine and see what you're doing. You really need some sort of recording capability, and suction is also advisable, but you can get away without suction, but most practices have suction. If we briefly have a look at the basics of an endoscope, how it works, or the anatomy of an endoscope, the universal cord, or sometimes called the umbilical cord, is what will connect the scope to the unit, and that's normally where light and air will come from, and some units where the connector to the camera will go as well. And then I would recommend for GI endoscopy is you really do need four-way deflection, which means that you need an angulation knob for up, down, and left, right. A lot of your bronchoscopy units will only have up, down deflection. And then you can rotate the scope, but it becomes quite challenging to get into the duodenum and to get around corners. So you really do want a scope that has a four-way deflection. And then there'll normally be some sort of working channel. And this is important as well. We'll get into this in a little bit, but you want a working channel that is wide enough that you can get decent biopsy forceps or instruments down it. Otherwise, you don't really get very good quality biopsies at all. So that's the sort of basic layout of an endoscope. The endoscope has got two little wires that run down the length of it, and these are attached to the angulation knob, which means that if you have the endoscope bent against something that can't move and you operate the deflection knobs with too much tension, you can break these wires. And these are expensive repairs. So you really do need to be gentle with your endoscope and to ensure that we don't break the wires. And then if we look at your basic driving skills, there's essentially, I said to you, we've got four-way deflection. So we've got up, down, left, right, but then we're also able to rotate the scope. So typically, if you rotate the handpiece, you turn it clockwise or counterclockwise, you're able to actually, in theory, almost have a 360 sort of maneuverability. Sometimes if you've done this before, you'll know that if you're inside an organ like the intestine and you're trying to rotate the scope, you just can't rotate it because it's bunched up in the intestine. But in theory, we're able to get more directions by rotating the handpiece, and then up and down, left and right will change in direction. So we do have a huge amount of versatility with this. Now, if you are already doing endoscopy, or if you're wanting to start, I like to liken endoscopy to learning to drive or driving, because there are a lot of similarities. Like, I do a lot of endoscopy workshops, and I think one of the things that I enjoy the most about them is to see people with very limited endoscopy skills. And when they start off and they're operating the scope, they're very deliberately making all the movements, thinking about them. And then towards the end of the workshop, they're actually not focusing on the driving, they're focusing on the task. That's very similar to learning to drive a car or operating anything. Initially, you're thinking about what you're actually doing, turning the steering wheel, operating the brake or the accelerator or the gear lever if it's a manual. And then after a while, you're not thinking about that at all. You're just thinking about where you're going and getting to where you're going. And so if you are starting, or if you're wanting to perfect your skills, you can liken this to driving. Is you can take some driving lessons, so you can attend a workshop, or you can have a colleague, like when you're learning to drive and a relative teaches you how to do it. Another thing that you can do, and I realize that in general practice that you are very time poor. Look, I'm time poor too in specialist practice, but if you have a cadaver or you make a phantom, you take a box, you cut a hole into it, you put a whole lot of paper towel and some toys, and then you insert the scope into that, and you basically practice your maneuverability skills. You can really improve your scope handling skills just by giving yourself multiple opportunities to practice the operation of the endoscope. The other thing that you can do is learn on the job. This is how I started. The first time I did endoscopy, my boss basically, and I was 2 or 3 months out, my boss just said to me, this is up, this is down, this is left, this is right, put it inside and see what you can find. I don't really recommend doing it that way. In hindsight, if I was a little bit better informed, I probably I wouldn't have done it that way, because I think I didn't know what I was doing, and I probably, I feel bad that I charged for that procedure. I don't think that's the way to do it. I think if you are going to learn on the job, you ideally need to learn from a colleague that's already done it before, that they can help you out and at least show you the ropes. So that's what I would recommend if you need to start, or if you're already doing it and you're wanting to hone your skills. Now, as a rule, endoscopy is best be a 3-man job, where at the moment I'm doing most of my endoscopic skills on the actual scope on my own. And it just takes a bit longer, and I just don't have as many assistants as I've had in the past. But ideally, the way that you do it is you have a vet and an assistant. So you have a vet and a vet nurse, ideally. So in this picture here, this is one of my residents. She's now sitting her exam, so she's completed her training now. So she's operating the scope, looking at the screen, and then next to her in the teal scrub is her vet nurse, and she is inserting and retracting the scope. So the vet is telling her in, out, or forward, backwards, what have you, and then the vet is operating the scope handpiece with the direction knobs. Now, you can do everything. That's what I currently do at the moment. I insert the scope and then I make the adjustments in between. And I've been doing this for a long time now, so I can get away with it, and I'm relatively proficient doing it. But it's much, 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 much easier to do it with an assistant, and particularly if you're learning. And then the reason it's ideally a 3-person job is you can see how the intense concentration of these 2 individuals doing this endoscopic procedure. And so the 3rd person is focused on the anesthetic. And you really do need a separate person focused on the anesthetic, because I am so consumed in what I'm doing when I'm doing this procedure that I wouldn't know if their heart wasn't beating. I can't really be monitoring their anesthetic. So if you're starting, ideally you have a 3-person team. Otherwise, the endoscopist will have to do the procedure alone, and you need somebody to focus on the anesthetic. So you don't have to have an assistant, but it does make it much, much easier if you do. And also, when you start to collect biopsies, and then you have to feed the biopsy forceps in, and you have to hold the handpiece and also then close the jaws of the biopsy forceps, it really does become very challenging if you don't have an assistant. So that's what I would recommend. Now, where I started, as I intimated earlier, I basically started in general practice. I had this old fiber optic endoscope. Many of you may not know flexible fiber optic endoscopes, but they basically are flexible endoscopes that have got a whole lot of optic fibers that have got little cladding between them. And when the fibers break, they no longer transmit light, and you have these black dots on it. So that's what that image is showing you. And I could only really look at the esophagus. I didn't know how to get into the duodenum. I didn't know what I was doing, and it was very, very frustrating. And I just felt like I wasn't growing, like I didn't, I wasn't getting anywhere. And so I didn't enjoy it, and I would avoid cases if I thought they needed endoscopy. It wasn't enjoyable for me because I wasn't trained. And I think some basic training, like with anything, you probably wouldn't go and do an advanced surgical procedure without any basic training, or at least skills that transfer over. I had horrible equipment. I didn't have any trained assistants to help me, so I was completely on my own, and I didn't feel like it was fair charging it. But whereas if I contrast it to today, I really love endoscopy. If I could do that all week, I would love to do it. I have good quality equipment, which helps. I've had training now. So during my residency, I had some training. I've been to some workshops myself. And so I feel like I have a basic skill level so that I can springboard off of. And I also have trained assistants. And I think it's good value for money now, because I feel like I can do the procedure quickly and efficiently. I can cause much less pain than a surgeon would. And I feel like it's good value for money. So if you look at building a unit, whether you have a unit already or whether you're looking to upgrade or whether you will be looking to upgrade, if we have a look at the system that I would probably recommend that you look at from the TK Vet Kit, it's the VHP 1315 system. So this is a neat little thing. I've been fortunate to have seen one of these and operate them. And so it's essentially like a laptop type design, where you have a self-contained unit that has got the light and the pump all in the same unit, with the camera cable, with recording capabilities, and it's quite a slick design. It's not very heavy, and it's compatible with quite a wide range of scopes that would be fit for your needs. So I've kind of underlined the scope that I think I would look at buying, or if I was starting and I was looking at setting up a unit, and that would be the GU 100. The code there you can read at GU 170 HQ. But basically, I'm looking for an outer diameter of around, as I between 6 and 9 millimeters. So 7.8 is a good diameter. Very importantly, the working channel. I really want a working channel of 2.8 millimeters. So if for 2.2 millimeters, we would be looking at for cats in particular, where you sacrifice the outer diameter, and then you have to sacrifice the channel width as well, the working channel width as well. And so the 2.8 millimeter for me, I'm just going to get big enough biopsy forceps that the pathologist is not going to laugh at me when I send them in. I have a friend who's a pathologist. He's not a huge fan of endoscopic biopsies because they're small. Pathologists always want you to send them the whole animal. You know what they're like. And so you get decent size biopsies with a 2.8 millimeter working channel. So I think that's a very good option. And then the other thing I've highlighted is the length. You really don't want to scope. 1.2 meters is probably the longest, I beg your pardon, the shortest I would go with a flexible endoscope for dogs in particular. And so cats, you can maybe get away with less length, but that 1.5 meter length is really convenient. If you were really big dogs like Great Danes, you can then have a longer scope like the 9.2 millimeter with a 3 meter length, but that's really going to be much more suitable for horses than for dogs. So for dogs, the perfect scope is to be around that 6 to 8 millimeter diameter, have that 2.8 millimeter working channel, and have a working length of at least 1.3 or up. So 1.5 gives us enough length. I have a 1.4 meter scope, and in bigger dogs, I can sometimes only just get into the duodenum. And so once I've got into the duodenum, I can't really go that far. Whereas if I can get into the duodenum and it's a small dog, I can sometimes get into the proximal jejunum with a 1.4 meter scope. So 1.5 is really perfect. So just looking at some of the options that we've got, if we're looking at the GU units that pair up with the little VHP unit, You've got your codes there, but as you can see, there's quite a few different options, flexible endoscopy options, including some USB modalities where it just plugs into a computer and then a camera is on the scope itself. That's a really good option for bronchoscopy. But if you wanted to save money, I would probably, you could do a lot of bronchoscopy with a gastroscope. You only would be limited for really small animals. And what I'll sometimes do if I have to use a wider endoscope and you're concerned about the diameter of the endoscope in the trachea, is you just attach the oxygen to the working channel and you're actually feeding oxygen through the working channel. So you're giving oxygen down the scope. So there's ways around not necessarily having to buy a whole lot of scopes. If you're just going to start, unless you were, for whatever reason, like a center that does a huge amount of respiratory work and bronchoscopy is most important to you, I would start by investing in gastroscopy, so upper GI, lower GI, endoscopy, and then I would branch out into bronchoscopy from there. So it's quite a versatile range, and so a lot of these units there are platforms and towers for them if you're wanting to have them sort of nice and neatly packed away. So that's probably how the system that I would look at in terms of getting set up. So if we have a look at some upper GI endoscopy. By far, as I said, the majority of endoscopy that I do is GI, particularly upper GI. I do quite a bit of lower GI endoscopy as well, so particularly rectal polyps or rectal adenocarcinomas or histiocytic or ulcerative colitis in French bulldogs and boxers. We'll sometimes do endoscopy for that. And then for flexible endoscopy, I sometimes will use a flexible endoscope for rhinoscopy, and particularly in mycotic rhinitis or sinonasal aspergillosis. So if you use a 3 or a 4 millimeter flexible endoscope and you have a big enough dog, and often your mycotic rhinitis or your sinonasal aspergillosis cases, they are long-nosed dogs that are bigger. I just find that with a flexible endoscope, it's much easier to get up into the frontal sinus, and that's where you get a lot of sinonasal aspergillosis. I'll often use that as an option instead of rigid endoscopy. And then cystoscopy, I've got a little video at the end showing you how in a male dog, you can use a flexible endoscope for urethrocystoscopy. And this is going to depend on your scope. So when you start off, you're probably not going to have a small enough or a narrow enough. You might decide to go to town and splurge. Maybe you work for a corporate that's got a big budget and they just throw money at you, or you own it and you want to max out the credit card and you buy a whole range of scopes. But normally most people are going to start with a gastroscope plus or minus a bronchoscope, and that's probably not going to be quite narrow enough to get up noses and into bladders. Okay, so if we have a look at some applications, I'll breeze through these very quickly. A lot of these are self-explanatory, but the one thing for which endoscopy has no equal is retrieval of esophageal foreign bodies. I always touch wood when I say this because I feel like fate has a sense of humor and it's going to happen to me next week. I've never sent an esophageal foreign body to theatre. I've always been able to get them out. Don't want to give the surgeons the satisfaction that they have to crack the chest to get a foreign body out. If it got in there, it can get out. So retrieval of foreign bodies is a major application of endoscopy. Gastric foreign bodies is a little bit more tricky because I've seen cases where people have taken well over an hour to get a gastric foreign body out because it's very, very fiddly, trying to get graspers on it, and it would take you 30 minutes to take it out surgically. So, sometimes I'm not sure. But sometimes you can get them out very quickly, particularly I've taken out valuable jewelry for owners before where they don't want to sift through poo to find it, and they want whatever bracelet or whatever has been swallowed. So I've taken things out like that before. For the diagnostic assessment of esophageal disease, it's very important. We're limited in our ability to diagnostically assess the esophagus. We've essentially got radiographs, which are very insensitive. We've got fluoroscopy, we've got endoscopy, we've got CT. And so endoscopy does play a very important role in evaluating the esophagus from an esophageal disease point of view. And then there are a couple of other things like chronic vomiting, melena, weight loss, where endoscopy can be an important component of that. So we have a look at quickly how we go about this. Well, fasting depends on your situation. You're not going to fast for an esophageal foreign body, but for planned endoscopy, I hate scoping in. It's just so horrible to scope a dog that's got food and kibble and fur and all sorts of things in their stomach. So when I do gastric foreign bodies, often what will happen is the owners, I don't know if they do it wherever you are, but if the dog swallowed something, they'll feed it a whole lot of bread to try and ease the passage through. And then you've got this sour bread and these foreign body all mixed together. And then the autofocus on the scope keeps on focusing on the object close to you, and there's mucus, and it's just a mess, horrible. So a 12-hour fast for upper GI endoscopy is a good idea. Then your preclinical pathology really depends on your situation. So you wouldn't want to do endoscopy on an Addisonian. So just satisfy yourself that it's not an Addisonian. If indicated, do a resting cortisol, rule that out. But that's going to be very much case dependent. And then also planning is so important. It's very important with endoscopy. So if you're going to be doing a procedure and you might need to put in a PEG tube, an endoscopic stomach tube, or you might need to remove a foreign body. I've been in too many situations in practices where, and it even happened to me at a university where it shouldn't happen, where midway during a procedure, we couldn't find an instrument because nobody knew where it was. And so someone had to go into the theater and get security to open it. And it was an after hours thing to find. It's horrible. You don't want that to happen. So I always try and go through in my mind everything that I might need beforehand and do a little simulation. And, visualize the procedure, for want of a better word. What might I need? Because I've just been caught out too many times like that. And also it happened to me very, very recently that I was midway through taking biopsies and my biopsy forceps broke. I was doing cystoscopy, so it wasn't biopsy forceps that I have a lot of. It's a small instrument that's quite expensive, and it broke. And it was fortunate that I was right towards the end because I discovered I didn't have a spare. And so I would have been really in trouble if I didn't have a spare. So what I'm getting at is just make sure you've got everything that you need. And it might sound obvious, but you'll be amazed how many times it happens that a procedure is half done or has to get aborted because you didn't have what you need. The other thing that I would say is to anticipate pneumothorax. I've had one case that I lost with an esophageal stricture that while we were trying to get past it, we perforated the esophagus and we had a pneumothorax. And we just didn't get it in time. So have someone keeping an eye out for pneumothorax, watching. This is why you need somebody on the anesthesia, watching the anesthesia. And they need to interrupt you and say, stop doing what you're doing. We've got a problem here. We need to address the anesthetic. So anticipate pneumothorax. I would have at least a 3-way stopcock or a needle or a butterfly or whatever it is that you might use close by, and you know where all of that is, that you don't have to look for that if you have a pneumothorax. Have that as part of your pre-procedural checklist. And then the other thing is, this might sound really silly, but check your endoscope before you use it. I had it happen it didn't happen to me. It happened to me before, not that it hasn't happened to me. I had a story very recently of a colleague of mine at a very well-known, prestigious hospital where they came to do endoscopy, and when they plugged the scope in and were ready to go, the scope was faulty, and they hadn't checked it beforehand and made sure they had everything ready to go, but they hadn't set it up. So especially if you haven't used this endoscope in a few months, and the last time it was used, it wasn't even used by you, and it might have got wet when it was, or got water into it when it was being cleaned. So I'm completely paranoid about this. I always check that the scope is working before the patient is anesthetized. So that might sound really obvious, but it's happened to me before as well. Positioning is important. And so basically, if you want to remember positioning for GI endoscopy, it's almost always left lateral recumbency. It doesn't matter so much for the esophagus what position they are, but 9 times out of 10, when you're doing the esophagus, you're going to go into the stomach and probably the duodenum as well. And so if they're in left lateral recumbency, the pylorus is away from the table and it's less likely to be squashed and it's easier to get into. And I become familiar with the anatomy in left lateral recumbency. So I don't like to change things around if I can. So just remember left lateral recumbency is pretty much the positioning for almost all GI endoscopy, with the exception of placing PEG tubes where you place them on the left. So they need to be on the right. And then there are a few things. They are prone to reflux. They're prone to regurgitation. So protecting the airway, inflated ET tube is very important. A gag is important. You've no idea how many times it happens that the dog will be coming to, or the cat, and they will chew down and they'll put a hole in your endoscope. The other thing that's commonly recommended is for the head to be slightly elevated. The reason I have a question mark for that is I don't actually agree with that, because if you have a reflux with a slightly elevated head and it makes it up to the back of the throat, it's more likely to pull in the trachea, or at least down to the cuff of the ET tube if their head is slightly elevated. I actually prefer their head to be slightly down. And then the other thing is, and I hope you don't think it's silly me telling you this, but you've no idea how many times I'll come into a room, or I'll be watching a workshop, or I'll be watching a colleague that I'm teaching doing this for the first time, and they're scoping in such an uncomfortable, awkward position. And so if you are the scope operator, make sure it's comfortable. The screen must be facing you. It must be in line with the scope. If it's perpendicular to the scope, then it becomes very difficult to operate it. And all you're doing is making it harder than usual. It used to frustrate the hell out of me when I would watch residents doing scopes or doing things like an FNA with an ultrasound, and they've got their back turned to the machine and they've got one leg up on the table because they don't want to ask their nurses to reposition the animal. So make sure you're comfortable and make sure that it's in the right position for you before you start doing it. Okay, so if we have a look at what a normal esophagus looks like, on the left we've got a dog esophagus, and then on the right we've got a cat esophagus, and the cat esophagus will have these striations which reflect the smooth muscle that is in the cat's esophagus. I have a little scope video from a cheetah that I scoped at the Australia Zoo, and I'll show you that cheetahs have cat esophaguses as well. They also have these striations. If we have a look at some of the disease processes that endoscopy is particularly useful for, and you don't really have a good other diagnostic modality, esophagitis. So esophagitis is one of those diseases where I always think there's a disconnect in how bad it looks and the organ that's affected and how clinically devastating it can be. So I have had a number of patients that the owners have ended up euthanizing them because of esophagitis, because of the degree of suffering. And so we most commonly see this post-anesthesia. Now, I've had the fortune of working in a few teaching hospitals where the anesthetists have a particular interest in this. And it's one of those conditions where preventing it is something where we don't have a good handle on exactly how to prevent reflux during anesthesia. So I obviously am generally on the side of diagnosing this post-anesthesia and dealing with it. But this is something that the anesthetists are obviously concerned about. In people, sometimes they'll use prophylactic proton pump inhibitors, but there isn't really a clear evidence of a benefit. Diet and length of fast is always controversial. There's some evidence that if you fast them too long, they're more likely to it, and if you don't fast them long enough, then they're more likely to reflux. The bottom line is that this is always a risk, and this is one of those things where, like I say to you, when you look at them endoscopically and you see the lesions, it often belies how clinically severe it is. So I've just got a few examples here. The image down on the left is an image from an endoscopy that I did in a dog that was regurgitating, didn't want to eat. had swallowing difficulty, was profoundly clinically affected, and the level of lesions is actually relatively subtle given how severely affected they actually are. On the right, that's not my image. That's an image I took from a textbook, but that's one with ulceration. So you can sort of understand how that might be quite severe and the level of discomfort involved. The other thing where endoscopy is very helpful is esophageal stricture. And so we typically are seeing this within a period of about 14 days after an injury or reflux or what have you. And the typical history is going to be that they vomit or regurgitate quite soon after eating. They often will tolerate food, but they won't tolerate solids. And then we have options for medical versus surgical management. Now, really, we probably shouldn't be cutting these out surgically. We can usually address them with balloon dilation. This is a simple procedure to do. You can order the balloons. You can sometimes get them from human hospitals where they are they've passed their sell-by date, but they've never been opened. And I don't know what the regulation is, whatever country you're from, but really that's not a huge issue because the worst thing that can happen is they break. And so you essentially identify the stricture, you pass a wire into it, you pass the balloon over the wire, and you inflate the balloon. The insufflator to inflate the balloon is not particularly expensive either. You can buy that with the balloons. This is practically a very straightforward procedure to do. You sometimes have to do it a few times over, but it's very technically easy to do, not a difficult procedure to do. And this is essentially what the procedure will do. The balloon will break open the fibers, but repeat treatments, as I said, are usually necessary. So if we move on from the esophagus and we move into the stomach, I guess, and I won't go through, I mean, this is pretty self-explanatory, and in the interest of time, I won't go through the indications, but you know, if we're suspecting a foreign body or we've got inflammatory disease or melena or what have you, we're going to do gastroscopy. But what's important is to know the landmarks. So you're doing surgery, you know your anatomical landmarks, you know where to cut. I haven't done this in a long time, so this is theory. So surgery is theory to me, but you know, you're going to know where to make your incision and what muscles you need to identify. It's exactly the same with endoscopy. You have a few important anatomical landmarks. And so the identifying the angular incisure or the angularis incisura is important because that is the demarcation between the antrum and between the body of the stomach. And then knowing where the cardia and the fundus are and being able to identify the pylorus. So if you can identify those landmarks, you can find your way around the stomach. And when you're lost, it really, really helps you if you know what the anatomic landmarks are and what you're looking for. 12-hour fast is usually adequate. And then we might want to also look at a couple of tests beforehand, you know, blood work or what have you to exclude extra GI causes. That's going to depend on the case. And then once again, left lateral recumbency, because we are going to probably want to get into the duodenum. So the procedure is relatively straightforward. And if the stomach is empty and you have a systematic approach, this is really pretty straightforward because as you come through the lower esophageal sphincter, you should be looking at the greater curvature. And if the scope is angled so that up is up on your screen, in other words, if you've kept your scope angled in the right way, then at the top and either too slightly to the left or the right of the screen, you'll sort of see a dark tunnel, and that represents the opening into the antrum. Another tip is that the stomach folds run in the direction of the longitudinal direction of the stomach. So you can follow your folds. If you follow along the folds, you can follow those into the antrum and into the pylorus. So that's your initial view. The J maneuver is to allow you to look into the fundus. Now, I don't do the J maneuver immediately. I do the J maneuver last when I've come out of the duodenum. And the reason for that is I don't want to overinflate the stomach, because if I overinflate the stomach, it's much more difficult to get into the duodenum. But the J maneuver is where you feed the scope in and you turn it 180 degrees so that you can see where the scope comes into the stomach. And the idea is, I had a case very recently where we did a CT on it and we found it had a lesion, a cancerous lesion in the cardia. And it was a big one. And so we went in endoscopically to biopsy it. I had a tough time finding it. And what struck me was, like, if I had done endoscopy because the dog was vomiting, I sort of thought I could have easily missed this lesion because I had to look really hard to find it. But I found it on the J view. So it's very, very important if you're looking at the whole stomach to do the J maneuver or the J view. And then, like I say, if you know what you're looking for, and the image on the right shows you the angular incisure. On the left, you can see the cardia where the scope is coming in. And basically, that angular incisure is the demarcation between the body and the antrum. And then the image on your left is the image of what the pylorus looks like at the end of the antrum. And often the pyloric opening is not in the center, which is a little bit annoying because it makes it a bit more tricky to get into, but it's often off just to the side. So that's what you're looking for if you're wanting to get into the duodenum. So if you're having trouble getting into the duodenum, you're not the first and you won't be the last. And I'm, touch wood, I haven't for a while struggled to get into the duodenum, but a couple of years ago when I said that, I had a real battle. But if you're battling to get into the duodenum, there are a few mistakes you're probably making. One, you're probably overinflating the stomach. When you overinflate the stomach, you essentially tend to collapse it so that the angle into the stomach becomes more of a 180-degree curve as opposed to the scope feeding in and being parallel to the long axis of the atrium. And also, what the image is showing you here is when you inflate the greater curvature and you feed the scope in, the scope tends to follow the path of least resistance, and it will feed into the greater curvature of the stomach. So it will get taken up by the greater curvature of the stomach, and that will create this this sort of almost circular, semicircle shape of the scope. And then you're pushing the scope forward and it's not traveling in the direction of the pyloric opening. It's actually traveling in the direction of the greater curvature. So I'm sure if you've done endoscopy and you're in the stomach and you've spotted the pylorus and you're feeding the scope, but the scope is moving backwards. It's moving away from the pylorus. So as you advancing into the duodenum, the image is moving further away. And so this is because the scope is being taken up by the greater curvature of the stomach. It's bowing into the greater curvature. So the remedies for this are, well, the easiest is really to try and remove the scope and to remove as much air. Sometimes what I'll get an assistant to do as well is to put external pressure on the patient's abdomen so that the stomach can't inflate too much. But sometimes if because you've inflated the stomach, you've made it flaccid, you've made it like a bladder with detrusor atony where it's just inflating, and the only way for you to do that is you have to keep on feeding the scope until it takes up the entire length of the greater curvature, and then we'll start to move forward. And that's where scope length becomes absolutely key. But if you want to avoid all of this right from the start, do the absolute minimal insufflation of the stomach that you possibly can. So when you come in through the esophagus and you come in and I'll just jump back. When you come in for the first time, just give enough of a puff of air just so that you can see where you're going and identify your landmarks. And that will greatly, greatly reduce the difficulty that you are having getting into the duodenum. And so that angle of approach is important because if you inflating the stomach, the scope is going to start to strike the pylorus almost perpendicularly. And so you really need to be patient then, and you need to wait for the pylorus to open and work it through into the duodenum. So if you're battling, this is commonly something I see at workshops. I see people really, really struggling to get in, and then they start over. So you're not the first and you won't be the last. As I said, try deflating. It is sometimes the case that the scope is too big. And in some cases, it's not that the scope is too big. There could be a pyloric stenosis or a pyloric narrowing. It might actually not be you. It might be the patient. But look, 9 times out of 10, if you're battling to get into the duodenum, it's the it's I'm not to criticize, but it's a failure of the operator to get into the duodenum. So like I said, know your target. So A shows you the little rosette, the pyloric opening. B shows you the opening to the antrum, where you can see to the right of that image, you can see the angular incisure, the opening to the pylorus. So if you know where you're going, it's much, much easier. As you enter into the duodenum, there's an unavoidable readout. That is when the scope comes into contact with the duodenal wall at the cranial duodenal flexure, and you just have to feed until it's well seated. And then you start to inflate, you wiggle it from side to side, and you essentially look for a black edge at the edge of your image, and you follow it into the lumen. So look, in the beginning, it's a little bit challenging, but as you do it more and more, it becomes more it becomes easier. And so when you get in, this is generally how you look. That's generally how you feel. That's a great feeling. Okay, so that's the basic navigation of the upper GI. So esophagus, stomach, and duodenum. We're going to focus a little bit just on esophageal foreign body retrieval, because this is something that really, ideally, if you have esophageal foreign bodies in your practice, that at a primary care level or GP level is something that we should be looking at doing. So I won't go into too much. I'm sure all of you have seen esophageal foreign bodies before. I won't go into the diagnostics and the history as much. But when we have a esophageal foreign body, planning becomes important. So clinical status, do you need to give them some fluids, some pain control? Do you need to stabilize them beforehand before you do it? Make sure you have the equipment to manage pneumothorax. And for me, I like to have a PEG tube available to place if the esophagus is badly damaged. Now, in my world, they often have come a long way, or they already have had some attempt to remove them, because I'm obviously in referral practice. So if the dog has just swallowed the foreign body and the owner noticed them swallowing it, and it's within a few hours, you probably don't need to be too concerned about planning for a PEG tube. But if it's a day or two that it's been there and it smells rotten and the esophagus is likely to be friable and torn, then you might want to plan for a PEG tube. So chronicity becomes quite important, because if they've been there for more than 24 hours, they often are quite friable, and the tissue is more likely to tear. And then there's a risk for aspiration, pneumonia, and pneumothorax, particularly with sharp bones. So these are some of the considerations. And then the other thing that is important is to have a few different plans as to how you're going to get them out. Now, I've worked with colleagues before that don't even bother trying to pull them out. They just push them in. I would say 99% of them, I've pulled them out. There would be rare exceptions if they are distal to the heart base and they're very close to the lower esophageal sphincter, where I might push them in. The argument of those who push them in, particularly bones, is that bones normally will be dealt with by stomach acid, but then a lot of foreign bodies, you run the risk of them obstructing the intestine later. So I like to remove them if I can. So just if you are, before you start, do you have stomach tubes of an appropriate size? Have you got grasping forceps? I like rigid grasping forceps, or a snare or a basket. Most vet practices will have lots of lube. We need a gag as well, remember. We do need access to suction, because sometimes we need to suction a whole lot of crap off of the foreign body before we retrieve it. An emergency kit for pneumothorax, absolutely crucial. This is the time you're most likely to cause pneumothorax. And remember, you are inflating that esophagus at the same time, inflating that esophagus while you are trying to remove a foreign body. There's a big, big risk of a pneumothorax here. And then also do you have the right size scope? And like I say, for me, I usually will have a peg tube kit. I don't think you have to have that for an esophageal foreign body, but it is a consideration. Very important. You can do it. I had a case where a resident struggled for an hour or two trying to get it out, and she was in tears, and she called me to come and help. And I came, and basically she got it out without me actually doing anything, just calming her down, talking her through it, getting her to go through her process, just getting her to believe in herself that she can do it. You can do it. It got in there, it can get out. So don't give up. Don't become overwhelmed and frustrated. If you have to take 2 minutes to sit down, even maybe have a short cup of tea, and get back to the task, then do it. But you can do it. So there's really a couple of major approaches that you can consider. I said you can push it into the stomach, and that's okay. But I will usually try oral retrieval first. And then you've got to think of a few things. How sharp is it? Has it been there for a long time? The size of the dog. You've got to take those things into consideration. But normally I will try and remove it. So the first thing you're going to do is you're going to find the foreign body. And so this is a bone in the esophagus. You're going to have a look around how much damage is there. And then you're also going to assess it. So in this particular case, I'm looking at this foreign body. I see a nice bony projection. I know I can get a snare over this. So I might not need to use rigid grasping forceps for this particular foreign body. Now, often they'll have a whole lot of cloth and bread and other stuff on them. You might have to pick or suction fluid and stuff off of them first before you're able to get your instrument on them. So clean up first before you start trying to grasp them. And then avoid overinsufflation. This is mainly to reduce the risk of a pneumothorax. As I said, clear the path. And then this is the risk to your scope. It's very, very easy to break your scope. So just be careful to protect your instrument while you're doing this. And once again, you cannot be monitoring the anesthesia in a case like this. It takes too much concentration. So this is an illustration of a nice bone, the kind of beautiful bone to have from a removal perspective. It's got a little projection on it. You can get a snare over it and you can pull it out. You can lasso it and pull it out with a snare. But a lot of bones won't have that. And so this is where you need some rigid forceps. Now, what you want with these rigid forceps is you want them to have some sort of rat tooth or biting mechanism. And then you want them to have a nice rigid shaft, and ideally a ratchet mechanism on the handle that you can lock them once they're on. Now, the way that I do this is I will identify the foreign body, and then I'll take the scope out, and then I will introduce the forceps based on the measurement from the scope. I'll introduce the forceps in the esophagus first, up to the point of where the foreign body is, and then I will ride the scope over the forceps. The reason I don't do it the other way around is because I've seen it happen too many times that you are feeding the instrument over the endoscope and you're damaging or puncturing the plastic. So I like to put the forceps in first and then go with the scope afterwards. And then using the scope to visualize it, you will maneuver the forceps to take a nice big bite onto the foreign body. And then a couple of important things. There's a tendency to give a good yank, and every time you pull, you get this reflux peristalsis. And it's hard to say exactly how hard to pull, but the esophagus of the dog is quite tough. So I find with small dogs, somebody usually has to hold the dog. Otherwise, I'll pull them off the table, pulling on the foreign body. But the most important thing is to do sustained traction. So you pull and hold, and then you gradually increase the amount of traction that you can until you feel it starting to move. And when it starts to move, you just try and keep a swift motion. Normally, it will start to slide. There are a few different places that it will be inclined to get stuck. So it often gets stuck at the thoracic inlet. But once it's in the cervical esophagus, then you or your assistant can actually massage it externally. They can help you externally to massage it up. And then another very important thing is to try and keep the neck as straight as possible so that the esophagus is absolutely as straight as possible. And then once you're done, you go in and you have a look. So you can see in image B, there's a hole in the esophagus. And the image below it, there's a hole in the esophagus as well. And if the injury is circumferential, so in other words, it's around the circumference of the esophagus, I'm a bit more concerned about possible stricture formation. And then you're going to decide on a feeding plan. So if there's a huge amount of damage, you might want to not feed for the first 24 hours or so, or in extreme cases, you might want to put a PEG tube in. Post-procedurally, there isn't really any evidence as to what the best is, and this is dependent on where I've worked. So a lot of clinicians will give omeprazole, most will give analgesia, some will give antimicrobials because they're concerned about the devitalized tissue. I hardly ever give antibiotics. The only exception to that would be in an esophageal perforation where I'm concerned there could be a pyothorax. I'll give antibiotics, otherwise I don't. And then fluids and supportive care. So basically the stuff that you would give based on the patient. So that's our journey through upper GI endoscopy. I really could spend hours talking about the applications with duodenum and ileum and colonoscopy, but I have to pick, I guess, a starter kit for you in terms of what's common, and I thought esophageal foreign bodies would be something that I'm sure pretty much all of us will see. So what I was going to do in the remaining time, and I do apologize for the length of this webinar so far, but I thought I would just go through a couple of cases with you just to show you some of the applications of endoscopy. So this is an endoscopy I did at the Australia Zoo for them. And so this was a cheetah, that's a 5-year-old cheetah with a suspected a Helicobacter, and they had a Storz endoscope, and that is a 7.8 millimeter scope. It's 1.4 meters in length, which is a little bit short. It would have been good to have a longer scope. 1.5, or even in the cheetah, 3 meters might have been better. And so the patient is in left lateral recumbent. So this is the opening to the stomach, the lower esophageal there on the lower esophageal sphincter, and you can see some fluid pooling. And so then this is as we're going through into, so this is as we go through into the stomach, we can see some gastric erosions there. Because it's a cheetah and it's a zoo animal and it has a set regimen, they weren't able to do a long fast, which they did check with me, and I did say it was okay, but silently, internally, I was suffering as a result of the dirty field. You can see the erosions there in the stomach. And there's some chicken or turkey or whatever they fed the cheetah in the stomach as well. It had a fast, but a relatively short fast. I don't like to fast the animals, the cheetahs, for too long. This is just an image. You can see how mottled this is. So we biopsied this, and this was a Helicobacter gastritis. I didn't have the post-treatment images for you, but the cheetah was treated with omeprazole and with antibiotics. Captive cheetahs are very prone to Helicobacter gastritis, and this had a history of chronic vomiting, and this cheetah has responded quite well to treatment. A little bit. So there we've got the pylorus at the end of the pyloric opening at the end of the antrum. So we're angling up, and you can see as we go in, there's an initial red out because there's a flexure as you go into the duodenum. And then basically we're feeding the scope, and we are moving from side to side. Now what we're looking for is on the edge of the screen, we're looking for where the dark shadow is, and we're going to turn towards that direction because that will take us into the lumen. So here I'm feeding, I'm insufflating, I'm moving gently side to side, up, down, and then feeding the scope to try and seat it into the duodenum. And then you see to the top, sort of top and of the screen, you see it's dark, and to the left, and I turn towards that, and then we're in the duodenum. In the duodenum, just the gastric erosions. The other case is, this is a very, very unusual case. So this is a case that I saw of a dog that was a border collie, and she had chronic vomiting, and she belonged to a vet nurse, and the owner of the practice. So the history I got was that they did a pyloroplasty because they thought the dog had a stenosis. It's a little bit of an unusual breed for a pyloric stenosis, but it was still vomiting, and the owner was concerned that the pyloric procedure hadn't been successfully done, and the pylorus was still too tight. So this is the history I've got. Of course, I don't know what it's like for you guys, but if it's a vet animal, often they don't have good written history. So I called the vet and I asked for a little bit more history. There weren't really written notes, so I didn't have much to go on, but I thought I'd go and have a look at the pylorus and see what it looked like. So this is scoping the stomach. This is the most bile I've ever seen in a stomach before. The stomach was just absolutely packed with bile. So all of that yellow material there is bile. And there was something off about the stomach anatomically, because now I'm inside the stomach and I'm trying to find my landmarks, and I just can't really find my landmarks. The pylorus in particular just seems very bunched, and you can see how hypermotile the stomach is as well. So here we're trying to find, we've got the greater curvature because we've just come through the lower esophageal sphincter. And then we've almost got this in front of us where we should just be seeing the greater curvature. We've got this sort of almost like amoeboid opening, which looks like it has to be the pylorus, but it just appears to be in an odd location. So we sort of go down in there, and I'm forcing the scope in there, but it just seems to be blind. It bounces back, and I'm back into the J view, which I wasn't trying to do. And then I look down, there's the pyloric opening there, but when I go in there, it's just blind-ended. I just can't get in. I can't find the pyloric opening, which is very, very, very frustrating. So I was on the verge of giving, and then view again, and I'm just struggling into the pylorus. So in this image here, we've got the J view. So we're looking up into the cardia. That's the angular incisor there. The angular incisor, and then we have the opening to the pylorus, but I get into the pylorus. Trying to get into the, and this is the second attempt trying to get into the duodenum. At the point of giving up, and then so that's the pyloric opening there, but there's just no access to it. And then while I'll just come back to it. I'll just pull this stomach. I see this hole in the stomach, and then I'm concerned that perhaps I've created a perforation because I've really been. But by then, you know, I don't really have anything to lose. There's this weird sort of opening or hole in the stomach. And so in the minor curvature of the stomach, and I can see villi. So I'm in the intestine. There's a connection to the intestine there's a connection into the intestine, the duodenum, through the lesser curvature of the stomach. Now, I managed to work out what had happened was they'd called this a pyloroplasty, but what they'd actually done is they'd done a modified Billroth procedure. They had anastomosed the distal duodenum onto the lesser curvature of the stomach and created a hole there. And so what was happening was all of the bile from the duodenum was just pouring into the stomach, and it essentially created like a 180-degree curve, because the pylorus now was essentially redundant. It was tacked back onto the stomach. So that was a very, very interesting. I'm not entirely sure how we would have diagnosed that without endoscopy. But what it illustrates is, because I tell you, this was a complex and frustrating case for me. And I had to call a surgeon friend as well and say, look, this is what describe what I'm seeing. And they said, yes, this sounds like a Billroth procedure. But what it illustrates is that if you know the anatomy well and you know what you're looking for, you can work out what's going on when you get stuck. The last thing I wanted to show you, and I realized that this was beyond the scope of what we're talking about, once again, no pun intended, but I just wanted to show you some of the novel applications for flexible endoscopy. So this is a dog that was an 8-month-old male-neutered Kelpie, and he was presented with a history of incontinence from birth with suspected ectopic ureters. We were using a 3.5 millimeter and this is entering the urethra and following the urethra. In the urethra, that's the opening into the bladder, the urethral sphincter. You can see the prostatic ducts there, those little kind of holes in the pelvic urethra. And then we're going to go through. So we're just positioning here, and now we're in the bladder. And we can see the urine in the bladder. So now what I typically do is I empty the bladder, because this murky urine makes it hard to see. You can see the ectopic ureter right there. I beg your pardon, the normal ureter right there in the trigone. And so we were very easy about identify both ureters in the correct position and exclude ectopic ureters. Doing CT would have taken half an hour or an hour for positioning and contrast, and then excretory urography. And with flexible endoscopy, that's the urethral vesicle right there, with the opening on the bladder side of the urethral opening. And in this view, you can see both ureters in the perfect location, and you can see urine coming out of them. So that's just an example of the wide applications for flexible endoscopy. Now, this is probably not something that you're necessarily confident doing day one, or if you are just starting, but the skills translate. So if you're doing gastroscopy, bronchoscopy, and you're proficient with skills, then you're ready to put the endoscope into another. So the last one I wanted to show you, sorry, I said that was the last one. This is a really cool case. So this is a cat that was referred to me, an 8-year-old female spayed cat with severe vomiting and anorexia. GP vet, hell of a nice guy, calls me up and he says, Irish guy, says to me, mate, I can see a really thickened stomach. If I can see a thickened stomach, there's something really bad. I'm not that proficient with ultrasound. So we refer it across for gastroscopy to assess the stomach and to obtain biopsies. So this is the before diagnosis and pre-treatment. So we're going down the esophagus. You'll see the striations of the cat esophagus as we get more distally. So you can sort of see that herringbone appearance of the esophagus. And then we're going into the stomach. We're now in the stomach, and it's just full of these erosions with these pale ulcerated areas. Almost looks like sort of calcification on there with these erosions. So these were throughout the stomach. And we biopsied these. I did impression smears of them, and I saw staphylococci and neutrophils on them. The biopsies came back as neutrophilic gastritis with secondary infection. Very unusual for a cat to have a bacterial infection of the stomach. So we were concerned about an underlying cause, perhaps a neoplasia or a lymphoma that we had perhaps missed. We put the cat onto some antibiotics, and the cat made a remarkable recovery. And then we decided for you. This, to let you have a copy, or for Rachel to give you the download link for this. I beg your pardon. Of the post-antibiotic shows that the lesions are gone. I'm happy to send you that video as well if you're interested in seeing it. So I'm sorry it's a bit of a rush at the end to get through. I'm just conscious of time, and thank you for your patience. This has taken us almost an hour and a half. I'm more than happy to take any questions, and to thank TK Vet for sponsoring this, and their partners who are selling the equipment. And as I say, thank you for your patience. I'm very, very happy to take any questions that you might have, or comments or suggestions, or if you have cases you want to share.
Thank you so much, Dr. Burchell, for your incredible, insightful presentation. You systematically guided us from esophagus to stomach to duodenum, and you also show us the landmark on the stomach to see how far we've been going, which is really useful and practical, especially for the beginners in endoscopy. Yeah, thank you so much for your excellent work.
My pleasure.
So next, let's move to the Q&A section. I already see some questions on our chat box, and you can also raise hand if you want to have a discuss with Dr. Richard Burchell. So Dr. Lesko asks, what are limitations of flexible versus rigid endoscopes in GI procedures?
So in GI procedures, if you were to use rigid endoscopy, you would really only be able to assess the descending colon and the esophagus, and depending on the size scope that you have, if you were using a 3 millimeter or 2.7 rigid scope, you might have some visualization, but you typically don't have a lot of insufflation on rigid scopes. So in other words, you don't have the flexible scopes will be able to push air through the working channel, and that opens up, because you must remember the lumen is collapsed inside the animal. You have to blow it open in order to be able to see it. So I personally don't really do any rigid endoscopy in the GI tract. So for me, rigid endoscopy would be noses, bladders in females, ears. So I'll do a lot of otoscopy as well, particularly with a CT as a companion diagnostic test. So the major limitation would be that you can't bend a rigid endoscope. And so really, from a point of view of GI endoscopy, flexible is really far superior to rigid endoscopy. So I see there's a question about with pneumatic lithotripsy through a flexible scope. So no is the short answer. The main reason for it is just the time taken and the type of caseload that I have. I'm not really in a urinary type center. I have had some experience where I've worked previously where a bulldog had lithotripsy performed for cysteine uroliths, and it took 4 hours to break it up and remove it. And I sort of felt a surgeon would have done that in half an hour. So that's not something that I personally am using at the moment. So I have had some exposure to it, but not really something that's a major.
Thank you very much for your answer. I was just wondering because I am marketing at this time some groundbreaking equipment that easily lets a GP break stones in urethra, bladder, and ureter. Without any external interference. And we just did a procedure yesterday, 2 days ago, I'm sorry, in a horse with a bladder stone the size of a grapefruit. And we successfully removed it. It took a bit longer because it was a test case, and we had the lithotriptic probe was too small, but the results were astonishing. It left the horse with only an incision of 2 centimeter instead of one of 10 centimeter. So same day, the horse went home and is happy as ever.
Yeah.
So,
Philip, I needed you today because we had a dog with an oxalate stone in its penis.
Yeah. Mm-hmm.
We had to do.
Well.
So the short answer is
should have called me sooner.
So I'd be I think I think there is a lot of potential application for this. The issue that we have here in Australia is just it's going to be obviously the cost barrier of the equipment, and then the other thing that I suppose is I imagine if you're able to do it in ureters that the diameter of the instrument is obviously quite narrow because
that's the biggest hurdle. So we're waiting on the people from TK Vet Kit to invent a scope small enough for male cats, for instance, to pass through the urethra, but that'll be challenging.
We will try maybe in the near future.
I will just put my email address into the chat, and then I'd be more than happy to chat with you if you're interested. And sort of because I have a colleague I think who would also be quite interested in this as well. She's in another part of Queensland, Australia, but she has a particular interest in urinary procedures.
Yeah, well, it's my business is really all the niche and new implementations of things. So it's quite groundbreaking, the introduction of extracorporeal ESVL, so electroshockwave lithotripsy, which is completely extracorporeal, and the pneumatic lithotripsy in small animals. So we had several cases where we were quite successful, and we're expanding. So we're starting in Belgium. I'm located in Belgium in Europe. The machine is invented by someone in Turkey. We work very closely together, and we're taking the market by storm. So if you're interested, just give me a shout out.
I will do. Thank you. That's really very interesting, and thank you for thank you for letting us know, because the issue in the past has just been the availability of it, and as you've said, the compatibility with some of the endoscopy units. I do have a disposable scope that I use for urethropscopy, but as you said, there's just nothing for male cats at the moment. The diameter of the urethra is just too small.
Okay, thank you, Philip, for your question, thank you, Dr. Richard Burchell, for your explanation. So since time limited, at last I would express my deepest gratitude again for Dr. Richard Burchell and for all participants who attend the webinar today. TK Vet Kit will have, in the near future, we'll have more webinars, covers multiple topics. Welcome to follow us on our social media and our local agent for more webinars, more opportunities to discuss with the specialists in the field in the future. Thank you so much for attending And let's stop here. Wish you have a nice day. Yes, we will record the webinar. We are recording and we will share to our agent, local agent, and they will share with you.
Yeah, I'm also happy for you to send a copy, that Dropbox link for the download of the PowerPoint, because that will have the videos in as well. So if anybody wants a copy of the PowerPoint, I'm happy for them to have it as well.
Yeah, we will
Sounds great.
share. Yeah. Thank you so much.
It's a big file because of the embedded videos. So, but if you have that Dropbox link I sent you, you can just download it.
All right. Thank you. Doctor, will you put your email address in the chat box?
Oh,
Yes,
yes, I will share.
Yeah, and I have a few different email addresses, but the one that's the best is the one that I've put in. That's the one I check the most regularly, and it's the one that won't change regardless of where I go. Yeah.
All right.
If I move around, I always keep that one. So that's the ideal one.
Okay, sounds good. You'll I'll get in touch with you.
Yeah, that'd be
Thank
fantastic.
you.
It's a great pleasure. And I can think of a colleague that'll be very excited as well by this. So I look forward to chatting to you.
All right. Thank you very much.
Thank you very much, Philip.
Okay.
Thank you. So let's stop here today. See you next time. Thank you so much, Dr. Burchell. It's an amazing
great pleasure.
presentation.
No, thank you.
Thank
It's
you
my
for
pleasure.
your effort.
Wherever everyone might be, have a good day or evening.
Have a good day or happy evening. See you next time.
Okay. Bye, Rachel.
Bye, Dr. Richard.
To stop sharing.